to look beyond the TOR, to be able to respond to issues, emerging issues beyond the TOR. Having said that,
I don't want you to answer. Yes, that's part of his comments.
Yeah. Having said that, I want also to restate a few facts that you'll be aware of. First is our Constitution and the reality of devolution, and the relationship that are supposed to exist between, how relationships between the national and county governments are supposed to be managed through the intergovernmental relations mechanisms. But also the fact that the counties, under the County Government Act, having devolved health services, then have a county public service board. And the fact that counties have the power to make laws, including budgets where salaries for health workers are going to be contained at the county level. Secondly, there is the voice of the health personnel, but there is also the voice of the recipients of health services. Where do the two come together? As a country, we have been grappling with this desire, and I'm calling it a desire with a lot of reservation, about capping our wage bill. But what are we saying when we come to the health services, to the very many health personnel at all levels that we are training and graduating? The question of unemployment, and as long as I am unemployed and have the skills, whether trained or acquired, to remove a tooth, I will remove it in the village called Nyarugumu, because KMPDC has no way of ever finding me in Nyarugumu. They don't even know. Even if they Google Nyarugumu, they may not be able to get there. Don't introduce Wamunyoro in hell. The other issue is the question of promotions for those who are already in service. Should healthcare providers be made to wait until there is a decision at the global level or at the national level for, I don't know, they are called common cadre promotions, or the number of people who have served for a number of years? And then there is a question of performance. And on performance, Dr. Ogo, allow me to provoke this. We have specialists who are full-time employees in the public service. And they will come to the clinic at KNH. 250 patients have been booked. They will see the first 10 at most, then leave. Is that fair to our people? When we compare the output of those specialists at Kenyatta National Hospital, at PGH Nyeri, and when they go across the road to Nelson Awori, to Upper Hill Medical Center, I can name all of them, and to Nyeri, when they go across the road to Outspan and Madari Mission Hospital and Tomotomo, how does their output compare? As medical practitioners, it is time that we really did evaluate this and then decide whether the way these specialists are contracted to handle clinics at Aga Khan or at Nairobi or at MP Shah, that whether that is something to import into the public service for specialists. The other issue for me is the question of health leadership. And really, we have struggled by trying to belabor the point about Dr. Amor. It is not about Dr. Amor or the DG. It is the lack of a deliberate and clear policy in developing health leaders which is one of the pillars of health system strengthening. And with strong leadership, then the issue of human resources for health and the key factor of budget and financing. And I dare ask, so if the magic bullet is the Health Service Commission, why have teachers been on strike more times than any other cadre or profession in this country, yet Teacher Service Commission is one of the oldest commissions? And therefore we need to ask ourselves whether we should really be boxed into a Health Services Commission, or all we need to do is to put together the structure and the resources required to make our sector work. Internship. Is internship a health industry gold standard that everybody, including the plaster technician, must do internship, or including the medical records guy?
I would want to give you guidance. You know, there are many of those other issues have been spoken by some other members. So I would want you to just limit yourself to, maybe you do not have the knowledge of what members spoke before you arrived.
All right.
You might be going through back to some of the issues that have already been spoken into.
On internship, Chair, I just wanted to ask, why don't diploma nurses undergo internship while other diploma holders are going through internship? How has it been resolved? And is it time we moved in that direction? Chair, on the regulatory bodies, does every cadre need to have a regulatory act and a body? I am proposing that we can have about 5 regulatory bodies: medical, dentistry, nursing, pharmacy, diagnostics, and rehabilitative. Those broad categories almost regulate the entire health sector. Chair, the question of digitization in 2 levels. The kind of interruption that AI and the Internet of Things has caused, the proliferation of online digital trainings, and whether that online training on Zoom and all the other platforms does confer on me the requisite competencies and skills to go out in the field and start doing orthodontics in dentistry. What is the depth of that training and how? It is a reality, but then how do we ensure that we attain the correct standards from these trainings? Then there's the issue of leakages within the healthcare system, perpetrated by healthcare workers. It is something we have all avoided to address. I hope this task force does pick that up. The issue of degrees has been raised. This country has a problem because apparently now, for you even to be appointed to a board, you need to have a degree. Do all diploma graduates need to have degrees? And would higher national diplomas and other qualifications be equitable so that then we do not all have to want to have a degree in community oral health versus a degree in dentistry? And the scope of practice is so divergent, but because I have a degree and the dentist has a degree, then I feel we can venture into the same area. Lastly, Chair, CBC, and the career path to medical services. The guy who will end up as an orthopedic technologist, what should he have? Should he be more of an artist than a mainstream?
Should be a carpenter.
That's what I'm asking, Chair. And therefore, This is another area where the medical profession is going to lag behind unless we pick it up at this level so that we can be able to guide the career path. Because CBC has been developed by educationists. They never really hooked it correctly to the different professions. Thank you, Chair.
Thank you, Honorable Madenge. I now want to come to Dr. Kamaroko to make your closing remarks.
Thank you, Mr. Chairman. Honorables, this couldn't be a better meeting for me as an entry point. This is just the appetizer. And on behalf of my team, we appreciate each and every input that you have. Our observation so far is that we are in this mess not because we don't know the solution. We are in this mess not because we do not have the capacity in this country to sort it out. In fact, if there's one country in Africa that should not be looking outside for expertise, it is Kenya. We have it all. Mr. Chairman, I was medical officer of health in Kwale district, then now county, in 1979. At that time, as MOH, you were only one doctor in the county. I've gone back to Kwale recently, and I found out that the output of the Kwale hospital, the same if not less, as what I was doing on my own. The cesarean sections, the hernias and everything. That having more people has not made us more productive, neither has the quality gone up. And we have allowed this sector to rot from inside. This sector is rotten inside and is deliberately done so. So the reason for our coming to talk to you is this. What we are seeing here, and I'm sparing you from this until we meet in that place, is that there is a moral imperative here for us to get this sector right. All this sector, somebody talked about the business model of running this sector. The policy framework in which we run this sector, it's not there. I'm glad you're raising the issue of the productivity of specialists. The hospital that you're mentioning that we should go and look for best practice, they don't employ specialists. They don't employ them. I've talked repeatedly about the magic of Ngong Road. That on one side of Ngong Road is Kenyatta National Hospital, with all the specialists that you ever want to have in a country, with all the equipment that's there. Fully employed, pensionable, including university professors. And then the moment you cross Ngong Road to the other side, those guys don't employ anybody. But they are extremely efficient in using the resources there. A treatise on the magic of Ngong Road is what we need to look at here. The nurse on one side of Ngong Road is very rude and rough. This same nurse doing a locum later on is the angel Gabriel. This is what we are dealing with here. And we are taking our task more seriously than any would have imagined. And we are saying that even if we are not allowed to look beyond what we are given, we are looking at it. Let somebody stop us. Because we are not dealing with an ordinary sector. It's a life and death situation. And this is, I believe, the opportunity for us to get it right. So if you can live here knowing that you, honorable members, are behind us, then we'll do it with the confidence that's required and give it. And give the stone the recommendations, even if the present government doesn't implement it. It has to be implemented for this country to be able to move to the next level. My final point, sir. We've looked at the income generation sides of this sector. This sector can generate and generates a lot of money. And it's interesting that when there is an income generation side in the Ministry of Health, there's no clarity on what it generates. This is the same thing that we have with the level 6 hospitals that can make money for this country and for this sector. This is the same thing that we have for the parastatals. We'll give you an example. The National Quality Laboratory, which is the one that's supposed to be testing all the drugs and everything that comes in here. That's an institution that should be making a minimum of 2 billion a year. Right now, it's hardly making 10 million. Because all the tests are now being taken to meds. So meds is making more money testing drugs for this country. And yet we have a whole parastatal with labs and everything else. So when we ask, who takes these things to meds? It is our own people who are taking it there because they eat with meds. And you can go on and on and on things that are there. You've just mentioned KEMSA. KEMSA gets 10% right now on all the donor-bought drugs. 10% of that, they're getting it just for storage and distribution. Nobody has given you the figure of what that is. Because if you look at the amount of money that donors, the USAID, PEPFAR and all, 10% of 45 billion is a lot of money. So why are we still funding it if it can make that and make more? So we are in this quagmire because we want to be here. And all that we need is for you people to encourage us. Let's work together and get this thing right. And for goodness sake, let's remove politics from it. Because disease knows no political party. Inefficiencies and maldiagnosis knows no political party. So if you can help us, let people know that the recommendations that we're going to make here are for the interest and posterity of this country and nothing else, then we will be comfortable in getting this thing. What we are seeing here immediately is that less than 25% of our problems require new legislation and new money. Less than 25% require new legislation or new money. Most of it can be sorted out with the current legislation, with the current budget. But somebody up there, the God Almighty, will have to get in all our hearts and all our heads to get this thing right. This problem that he said is between the county and the central. This is all created by us. There's really nothing to fight over. This problem that we have here, that health workers need to be under a commission. If we can work together, then the thing that they want can be done currently. This problem that we have here, that people cannot be transferred from one county to the other, honestly, it can be done if we all agree on the rules of the game. It is just the rules of the game, and we move forward. So we are very, very hopeful. I don't want to use the word optimistic, because you can be optimistic, but you have no hope. We are very, very hopeful that when we meet together, and we want to meet with you finally when we have everything else, that we can come out with a recommendation that nobody is going to oppose, because it is not a political issue. One final thing. We're going to be meeting SHA. We have not met them yet. But we're going to meet them because every new thing, new law, new legislation that you people pass has to ask the question of the implication to the human resource. So when you pass the 4 laws, we ask, what is the implication for human resource on that? And human resource is never taken to the priority thing. So I'm going to request that even as you focus attention to SHA, SHA is a secondary thing to human resource. Please give more attention to human resource. If we fix this and we get the integrity in place, we get accountability in place, we get the communication and the coordination in place, then SHA will work. It doesn't matter what you call it, it will work. But right now where we are in this cliff edge where we seem to be moving forward, but the wheels of the vehicle are turning in the air. They're just rolling, but we're not moving forward. And this is our quest. So, Mr. Chairman, sincere appreciation from me and my colleagues. I feel that we are speaking the same language. I believe that we have a responsibility for this country to get it right. And I can assure you that we are going to get it right. Thank you very much.
Thank you, Dr. Kamaroko. Thank you, members of the task force. One of the issues which I had asked my legal counsel is about the amendment bill to the national referral hospitals. Currently, that one is at the government printer. It is being printed. So once Parliament resumes, then it will be done the first reading and the process will continue. We will have another meeting with the task force, but we want it to be towards the tail end when your report is ready, so that we can look at, we can go through some of your recommendations that needs action from this committee, especially in terms of amendments to the various health acts, and then also at the policy, what is it that we can be able to do, and also at the budget level, what is it that we need to capture for that. This committee will support this task force. The process that you've taken in coming to consult us is the right one. And we are happy that we are all in sync with what the task force is doing. We'll support you. This is a noble idea, and I want to thank His Excellency the President for having considered and appointed this task force to do this. This is not going to go in vain. We should be able to implement, and I don't think the President would be doing anything in vain. He has all the good intentions to make sure that health service in this country is in the right path. One of the pillars is the UHC, which I think, as you rightly put, you're going to meet with SHA, because they are the primary implementers of the UHC. And we are hoping that we know there are teething problems with the way it's being implemented, which is expected for any new program that comes into effect. And with all those teething problems, we should be able to manage it. And if there is any input that as a committee and also as a task force you can recommend, that will go to the right way to make sure that we are able to deliver to the Kenyans. Thank you for coming out of retirement. We've not met, but I knew you as my chair of KMA when I was a member of KMA. I worked in Baringo. Then Dr. Nyikal came in and negotiated with the former President Moi a better package for us, and things worked well. I'm one of those healthcare providers who never did any locum. I only worked in a government facility. And I know that it is possible to work in a government facility and deliver. My colleague here, Dr. Arwasa, I think is from the medical CEOs that worked in the national referral hospitals. I think is one of the best ever CEO that we can, as a committee, forge for him. So he has a good experience from running the Moi Teaching and Referral Hospital. And the Moi Teaching and Referral Hospital under his stewardship did very well. And I think it is still on the right path. As a committee, we've been there. And so Dr. Arwasa will be able to at least give this task force his input as a former CEO. So with those few remarks, I want to thank the task force on behalf of my health committee and my secretariat. The secretariat of the task force and my secretariat will work together to fix the next appointment to a more convenient venue as requested by Honorable Sunguli. So with those few remarks, our meeting is adjourned. We will not have the Thursday meeting with SHA as the committee because we've not given them the copy of the Hansard, and they need to have that copy of the Hansard from the Naivasha meeting, and they've requested, I think their letter is coming. I've told them to write official so that we give them time to give us a comprehensive response. So, honorable members, you can be able to plan your week accordingly. I think that's for the members, so that you can plan, for these members, we work in Nairobi, but we also have a responsibility in our constituencies. So with those few remarks, our meeting is adjourned. Thank you very much. We can go for the photo session. Hassan, where? Outside.